So welcome to Workshop 23, entitled Out with the Old and In with the New, Clinical Guideline Update. I think you have all seen this slide a million times, so we'll keep going. I am Darcy File, pediatric nurse practitioner with UW Health Kids CF Center in Madison, Wisconsin. And this is Christy Woods, nurse practitioner with the Adult CF Center of Central Texas, affiliated with UT Austin. We are your co-moderators for this session. I am not cool enough to have any disclosures, but Christy is cool enough. She has a relationship with the LEAP program through the CFF.
And that's just a shameless plug.
Let's see. The description and objectives for this session are listed in the program, as well as on this slide. And the bottom line is we just hope that you learn something new from this session and are able to take it back to your CF center to improve patient and family care. So this session is going to be a little bit different than a typical workshop. It's going to be a hybrid. We have 3 invited speakers, similar to a symposium, plus we have the 4 abstract presenters. We'll begin the workshop with the new CRMS guidelines that were recently published, followed by a brief Q&A session. Then we'll transition over to the new CF liver guidelines that were also recently published. This will be followed by 4 abstract, This portion will start with 2 presentations, one with the peds focus and one with the adult focus, addressing some of the changes that you might see in your population. Then we'll follow that up with the 4 abstract presentations discussing the implementation of the guidelines into clinical care. Lastly, we'll end the workshop with a Q&A session that includes all 6 of the liver guideline presenters. So we ask that you hold your liver questions until the very end of the workshop. So let's get started. So our first speaker is Dr. Deanna Green. Dr. Green is a pediatric pulmonologist and the medical director of the Cystic Fibrosis Care Center and the CF Therapeutic Development Center at Johns Hopkins All Children's Hospital in St. Petersburg, Florida. Dr. Green is also an assistant professor of pediatrics with the Johns Hopkins University School of Medicine. She holds a master's in health science degree from the Johns Hopkins Bloomberg School of Health, with an emphasis on design of clinical research trials and clinical epidemiology. She is therefore focused on clinical care for patients with CF and clinical quality improvement research to advance all pediatric CF care. She was able to co-chair the guideline committee for the revised CRMS CF SPID guidelines, which were just published in the early part of 2024. She will be presenting revised 2024 U.S. guideline on CRMS CF SPID. Please welcome to the stage Dr. Green.
Thank you to the moderators for inviting me for this. For contextual purposes, I am from Johns Hopkins All Children's, which is in St. Petersburg, Florida. My house is fine. I did not have flooding. However, my coworkers who are here have had flooding, as well as many of my patients. So please keep them in your thoughts, but I am fine. For further context, I know most of you are here for the liver guidelines, just as I am. So I apologize if you don't know any of these acronyms, but we will get through them, and please feel free to ask questions at the end. So I have no particular relationships to disclose related to this. The CFF does have a conflict of interest with anything related to CFTR modulators. My objectives are to review these guidelines with you and help evaluate the rationale for why we are making recommendations towards repeat sweat testing and reassessing the designation of CRMS. We will also highlight some shared decision-making with families regarding the appropriate team members, as well as follow-up evaluations and further treatments needed for these individuals. So CFTR-related metabolic syndrome, or CRMS, has been used because of early CF diagnosis through the advancements of newborn screening. Newborn screening has been associated with better outcomes overall for our patients, and there was rapid involvement of newborn screening from 1999 to 2010 and expanded from 2 states to all 50 states currently. In 2009, we convened the first group expert panel to create guidelines for the care of infants with a positive newborn screen, but inconclusive diagnostic testing. This is when we first coined the term CRMS within the U.S. It does not imply an infant has CF, and it did include variants at that time that we refer to as variants of unknown significance and variants of varying clinical consequence. That first guideline really focused on treatments of the newborns up to about age 2. We then proceed to have the CF care diagnosis guidelines. In 2015, the CFF again convened a consensus conference on CF diagnosis, again in response to the rise in newborn screening diagnosis. The definition of CRMS was again addressed. And to be clear, CRMS means that you start with a positive newborn screening test. Not that you had symptoms, you had a positive newborn screening test, and then you have a sweat chloride that may be less than 30, and you have 2 CFTR mutations, one of which has unclear phenotypic consequences, or you have an intermediate sweat test between 30 to 59, and 1 or no CF causing mutations. At the same time as this definition was created, the European group also created an analogous term. They use the term CF screen positive inconclusive diagnosis, or CF SPID. We therefore moved forward, and in 2021, we decided we needed to update our 2009 guidelines, and we convened a group involving 11 physicians, including representatives from Europe and Australia, 2 newborn screening coordinators, 3 program coordinators, a nurse practitioner, a dietitian, 2 social workers, a psychologist, 4 genetic counselors, and especially 3 parents of children with CRMS CF SPID. This has now been peer reviewed, and it was published in Pediatrics at the beginning of this year, 2024. It's completely available for open access. We developed 31 recommendation statements that had been developed from 24 different PICO, which are patient intervention, comparison, and outcome questions. We have 30 final statements that met our consensus, and we overall use the U.S. Preventative Services Task Force grading system. This is kind of what that model looks like. This is the grading system from the USPST. We're going to really concentrate on a lot of grade Cs. That is what we have. And usually that means we're selectively offering. So we're offering to provide this service for selected patients depending on their individual circumstances. This means there's going to be a lot of shared decision-making and discussions to be had with the families. Just to preface all of these recommendation statements that we're going to fly through in a minute, a lot of our text is actually related to the first 5 statements, which are genetic statements. And so these are really a refinement to help appropriately classify people to make sure that we actually think that we're dealing with someone with CRMS, CF SPID. Every state does newborn screening in a slightly different manner. And this diversity actually needed further explanation so that we can appropriately classify individuals. As of 2020, all states provide an IRT followed by a genetic screen, but that genetic screen can vary from a single variant, F508del, to other states that actually have a next-gen sequencing. Our current guideline, the newborn screening guideline, which is now open for public comment, may also help to further refine this. So these are kind of used hand in hand as some guidelines. You have until October 8th to look at that guideline and provide some public comments, please. So getting into our statements. The genetic statements start with anyone who has fewer than 2 disease-causing variants identified by their newborn screening, that they should have sequencing of the coding and flanking regions and a deletion duplication analysis of the coding and exon flanking region. Again, this is to better refine and make sure that you know what are the variants that that particular individual has, and do they have 2 variants or not. If that remains inconclusive, then selectively offering full gene CFTR sequencing, which includes intronic regions, could be performed. A lot of people refer to this as intronic sequencing. Not exactly the right term, but the idea. To be clear, though, in the US, this can be very cost prohibitive. There's only a very few testing sites within the US, so a lot of discussion should actually be had if you feel like you need to move on to this point if you've done a full sequence already. We would recommend that parental testing be done to determine the phase, It's very common that you actually have more than one variant on a chromosome, and therefore, if you're seeing two, it may actually have come from the same parental lineage. We also wanted to help refine who we consider to be the care team for this patients. We do recommend healthcare professionals providing genetic counseling should have training and/or clinical expertise with CF and genetics. A licensed or certified genetic counselor should be accessible to all families and people with CRMS for further support, and especially for discussions regarding future reproductive decision-making. At least annual follow-up by a CF clinician and nurse with an initial assessment including social work and/or mental health coordinator and/or a genetic counselor. Continued follow-up later by social work, mental health, or a genetic counselor is depending on the needs of that particular family and individual. Again, this is a refinement of the 2009 guideline and given to us by feedback through our surveys that many of our care teams did not really know who should compromise and be part of the care team for this individual. At that time, genetic counselors were not actually full members of the CF care team, but as of current, the recommendations and the new care model guidance actually does cover this, and we have elevated genetic counselors to a status within your center. This is kind of our key recommendation as well. Repeat sweat testing at 6 months of life and annually, at least until age 8. This is a significant difference from the European CF guideline, and they were recommending to keep performing until about age 6. But the systematic review of literature really supports repeat sweat testings until about age 8. There is often a delay in elevation of the sweat chloride for people who have variants of unknown significance or varying clinical consequence. At this current moment in time, though, there is no evidence to do repeat sweat testing after the age of 8. It's hard to say if that will happen in the future, as well as we would recommend that you may need to keep individuals continuing with testing if they are seeming to have a rapidly rising sweat test. So let's say all of a sudden they went from 40 to like 58. You may want to consider, maybe I'll continue following that patient. We're recommending selectively offering routine cystic fibrosis respiratory cultures at each visit. And if there is a clinical indication, in the 2009 guidelines, we had recommended doing this at every visit regardless of symptoms. The European guidance recommended performing when clinically indicated, and our recommendation is again offering, but having shared decision-making with the families to determine if that is necessary. Most of these individuals, again, are well, healthy, and having no clinical symptoms. Fecal elastase should be performed at the initial assessment. Further testing of fecal elastase would be provided when clinically appropriate. The European guideline, again, recommends at the initial visit and at 12 months. We do recommend this because if you are in a state that has incomplete genetics, pancreatic insufficiency is actually more commonly associated with CF than CRMS. So this may help further refine and help you be directed towards further genetic testing if necessary. We recommend against other routine laboratory evaluations, however. You don't need those fat-soluble vitamins, you don't need your CBC, you don't need your liver testing, and this is really to avoid over-medicalization of all of these relatively healthy individuals. We also recommend against routine pulmonary function tests. Again, there is no current literature that states that spirometry, multiple breath washout, or any other PFT is informative to help you determine if a patient is going to make a reclassification to CF from CRMS. This is different than the European guidance, which also said that this should be done as a comprehensive evaluation around age 6. We recommend against routine chest radiographs for people with CRMS. We also were considering whether or not we should recommend chest CTs at age 6. At the time, our committee was unable to come to a consensus regarding this, so no recommendation is provided. Many committee members felt that we could not recommend an evaluation that at the time was not being recommended for people with CF, and otherwise healthy populations are not normally exposed to chest CTs on a routine evaluation. We do recommend implementation of standard CF infection prevention and control guidelines within the healthcare setting and any situation where they might be a high likelihood of being in close contact with people with CF or CRMS. Selectively offering inhaled antibiotics for the treatment of Pseudomonas aeruginosa may be given based on a positive respiratory culture. Again, you just heard those were actually being selectively offered to the patient. So if you actually do the testing, you should decide how you want to treat. That, however, should be with shared decision-making with the family, because this could be relatively burdensome. The monitoring of weight remains within the purview of the PCP, but if you are noticing a downward trajectory of weight, then pulling in your dietitian who has expertise within CF and hopefully the management of CRMS, CF SPID would be appropriate. We are recommending against salt supplementation or the use of fat-soluble vitamins for these individuals. We are also recommending against the routine use of airway clearance, but for those with new respiratory symptoms, selectively offering the use of airway clearance should be provided. Again, similar to starting our oral antibiotics or inhaled antibiotics for Pseudomonas, if we have a cough that's lasting more than 2 weeks, share decision-making with the family to determine whether or not airway clearance should be used when those symptoms arise. The least burdensome airway clearance would be our best guidance. Again, maybe just some manual percussion, which most families can actually figure out and do, and probably should do during viral season anyway. We do have inconclusive evidence for use for or against the medications that are most commonly used to treat respiratory symptoms of CF, such as Dornase alpha, hypertonic saline, and or even thrice weekly azithromycin. The clinical benefit of these specific therapies have not been studied within CRMS. These will add significant medical complexity, treatment burden, and costs to the families. And if there are these types of chronic respiratory symptoms that you are starting these medications for, you may want to have a reevaluation of whether or not the patient actually has CF. The Guideline Committee recommends against the use of CFTR modulators for people with CRMS. Again, if you are considering the use of modulators, then reassessment of the diagnosis should be made to determine whether this individual actually does have CF, which is the current indication for use of modulators. And then we close these guidelines with a lot of communication and psychosocial recommendation. So we would recommend considering social determinants of health that influence the understanding and psychological impact of this particular diagnosis and help to tailor your communications to this appropriately. Healthcare professionals should be able to tailor their communication about the specific CFTR variants and base that on shared decision-making to minimize psychological, cognitive, or other barriers to processing of this very complex genetic information. Providing clear, concise, consistent, and recurrent timely information about the uncertainty related to CRMS diagnosis, and continue using family-centered communication strategies during the entire time that the patient is with you in clinic. Short, gradual, clear, and consistent verbal and written developmentally appropriate education should be provided multiple times within your evaluation, but most importantly at diagnosis, each of your follow-up visits, and at any time of reproductive decision-making. We also encourage that primary care providers and other health professionals who are involved in the care of these individuals with CRMS receive accurate and up-to-date education about CRMS, its management, and the state's newborn screening program. If your state is going through changes within their newborn screening program, you're probably going to need to update those PCPs because you're going to have patients falling in different categories over time. We also have some mental health statements. At least one primary caregiver of people with CRMS should be offered screening for depression and anxiety annually. This is consistent with our current mental health guidelines for CF. And if there are individuals being followed in the CF Care Center over the age of 12, we also recommend that they be screened for depression and anxiety. And this is provided annually. Again, still consistent with the mental health guidelines, and we recommend use of the GAD-7 and PHQ-9, which are routinely used in our CF centers. So this is the table from the paper, and this is our kind of guidance on follow-up and schedules, so hopefully that's better in a more graphical form for you. And then some final considerations. The European guidance actually had a discussion of discharge from the clinic. We do not specifically state this in our guidelines. Again, there is no evidence to suggest further testing beyond age 8, but that may change over the course of time. And so discussion with the family regarding any signs and symptoms and things that they should monitor in the future needs to be had before you are willing to discharge this patient from your clinic. In the European guidance, it suggests also that CRMS may be on its pathway to developing CFTR-related disorders. Those would be individuals who are found because they have symptoms, and we backtrack to doing genetics, finding multiple genetics for them. So slightly different than you came in because you had a newborn screen with no symptoms. It's unclear to us if this is actually the true pathway for any of these disorders. It may actually be very dependent on some specific variants, and we just do not have that data available at this time. So we felt this was out of the scope of this particular guideline at this time. So in summary, CRMS is going to remain a common outcome from CF newborn screening. Most individuals with CRMS will remain healthy, although there are those that do reclassify to CF. And a balance between over-medicalization versus no further follow-up will need to continue. We ended up erring towards recommendations with an emphasis on the most valuable test to keep performing annually, which is the sweat test. We do acknowledge, however, that this alone can cause significant distress to families, and this does need to be discussed and justified as well. And finally, we have lots of unanswered questions. We don't know about the utility of the CT scan. We don't know about chronic daily therapies we typically use for CF. We don't know if there are any specific likelihood that a particular variant is going to go on and reclassify to CF. Could this be the VVCCs versus the VUS? It's very hard to say. And we do not know if there's any likelihood to develop a CFTR-related disorder or not. So that is what we have, and I think I'm supposed to have some time for questions at this point.
Yes, so feel free to come to the mics in the center aisles, or feel free to use the app if you have any questions. So any questions out there?
I was going to say this is perfectly clear. I'm so excited.
Well, no, we're not.
We must have done great.
So there are a few questions on the app. So the first one is, to get the slides for this presentation?
Can we give the slides? I'm happy to give the slides. However, it is all in the guideline on pediatrics, and everyone has open access to it.
Was that table that you displayed with?
Yes, that is table 2 in the guideline.
That was my question. Let me
No
just
worries.
clarify. I like visuals. Next, we have if a patient screens positive for CF but has a normal sweat, you recommend complete DNA sequencing to ensure patient does not have 2 mutations and need to continue to be followed.
Correct.
That was an easy one. Okay. Next, we have what are recommendations for testing siblings who had a previous normal newborn screen, but now with a sibling with identified mutations or variants?
So I didn't present every single one of our guidelines. I went through that. That it is something that should be discussed and that it's offering it to the family. It is not being mandated in any way, but that at least offering potential for genetic testing is provided to a sibling.
Yes, there are more. Sorry. It's just like
It's all good.
They're all popping up.
Previously, the app crashed on other groups. So if we can see them, that's great.
Okay. So then let's see. I guess someone stated the flow chart is not in the paper.
The flow chart. I do have a flow chart, but that's because it's from a different paper.
All right. When you move from a CRMS DC to a CFTR related
you might mean this
disorder
one.
diagnosis? Are you, I have to clarify the question. So when do you move from a CRMS diagnosis to a CFTR related disorder diagnosis?
We do not discuss that in the guideline. There is not any way for me to actually inform you of when you might move to that diagnosis. But again, keeping in mind CRMS, you would have identified the individual because of newborn screening, so they were a baby. And if you're trying to relate to somebody who has CFTR related disorder, they probably have some sort of symptom. So if they came by symptoms, they have the same set of mutations, it would be CFTR related disorder. You need to decide clinically, does that patient actually have cystic fibrosis? Keeping in mind, in the end, cystic fibrosis is still a clinical diagnosis. It really means that you have at least 2 organ system involvement beyond what your genetics or what your sweat test actually informs. So if you have 2 organ system involvement, 2 positive CFTR variants, you may want to consider, does that person actually have CF?
Deanna, can you put up the slide that had all of the, that one? Yeah, I didn't know if people
yeah,
wanted to
the
take a
schedule,
picture
that
of that.
Yeah.
But that's in the paper.
This is in the paper.
Yeah.
Okay. And then what materials will the CF Foundation be helping provide to smaller clinics to help with communication to the broader population coming to us from multiple sources in primary care?
Wonderful. We are working with the CF Foundation currently. We will be having a commentary on these guidelines within probably the next 6 months. We are working on additional webinars and other pamphlets that we can give for you for educational materials within the next year.
Dr. Farrell?
Phil Farrell, Wisconsin. Thanks very much, Deanna. I think people want.
Thank you.
Can you hear me right?
Yes, we can hear you, but thank you for all your work.
I think the reason people want your slides is that your explanations of slides are a lot easier to understand than going through the publication, which is dense. It really is a dense, valuable publication. But I wanted to ask you, did your committee discuss the probability of reclassification or conversion from CRMS to the diagnosis of CF? What I know the literature suggests anywhere between 10 and 44%.
Correct.
But I wonder what the sort of consensus of the committee was about that probability, since I think that's the key reason to follow these patients, because a certain percentage are going to become patients with cystic fibrosis. Actually, they had cystic fibrosis from birth, they just didn't have diagnostic criteria.
I completely second with what you're saying. Again, if an individual reclassifies to CF, they had CF since birth. Their genetics did not actually change. So we did talk about that, and that was kind of one of our driving forces regarding all of these recommendations. There is a variance, as Dr. Farrell correctly stated, anywhere from 10 to 44% based on whichever study you're trying to cite. And a lot of that then incorporates into, well, what did they study to make that determination? And what really happens in the very high group that reclassifies, almost all of them are reclassifying because their variant of CFTR actually got reclassified. So changing it from a VUS to an actual pathogenic variant. And that's very important that you are taking the time as the individual caring for these individuals to keep looking at CFTR2.org. That's probably our best resource that has been developed over time. They have recently reclassified, and there is now over 1,100 variants within CFTR2 listed as pathogenic. So again, keeping up to date with that every time you meet with this individual annually when you are rechecking, has the variant that you're looking at recently been reclassified? But that was really the only thing that informs it, as opposed to any other studies like PFTs or x-rays or otherwise.
Great. We are out of time. Thank
Come
you
find
very
me
much.
later.
Okay, the stairs always feel a little rickety.
Hang on.
Oh, you are?
Yes, sorry. Okay, so our second speaker today is Dr. Lauren Lazar, and she's an assistant professor of pediatrics in the Division of Gastroenterology, Hepatology, and Nutrition at UT Southwestern Children's Center in Dallas, Texas. She's a former CF GI fellow with clinical training grant awardee and participates in CF care and research at her center. She will be presenting new cystic fibrosis liver guidelines, a pediatric perspective.
I'll try again. Okay, so thank you to the moderators for inviting me to speak on the pediatric perspectives of the new guidelines. And special thanks to my mentor and colleague, Dr. Meg Sate, although she's presenting somewhere else right now. So no disclosures. All right, so these are our objectives today. I'm going to go ahead and dive right in with the first one, starting with the importance of liver disease in pediatrics. So as you all well know, liver disease in CF has long been thought to be a childhood disease with the peak onset in pre-adolescence between 8 to 12 years of age, as shown in this visual here. So therefore, if liver disease in CF is a childhood disease, then morbidity and mortality is extremely important to monitor in pediatric patients. So in this 2018 paper, there was noted to be high morbidity and mortality in the 10 years following diagnosis of advanced liver disease in CF, with occurrence of complications such as variceal bleeding at a rate of 6.6%, liver transplant around 10%, liver death 6.9%, and all-cause mortality to be 39%. So liver disease in pediatrics is also important due to unique considerations in children, including potential for presentation of neonatal cholestasis and rising rates of pediatric obesity in today's post-modulator world. So as you can see, there is a shift towards being overweight or obese in persons with CF after starting highly effective modulator therapy. And this has implications and new ramifications for hepatobiliary disease and cystic fibrosis. In a 2021 study with ivacaftor, obesity increased from 9% to 18% in pediatric patients. And while there is limited published data on ETI and pediatric obesity, adult studies have shown significant increases in both BMI and body weight trajectories. So now we will move into a deeper discussion of guidelines. As you all will recall from the prior guidelines, there was heavy emphasis on physical exam and annual lab work. Imaging was only performed as a reactive assessment to persistent abnormalities rather than as part of a proactive screening program. So however, with the new guidelines that emerged this year, there is a much heavier emphasis on utilization of imaging and fibrosis markers as part of screening for liver abnormalities in children with CF. So where did the evidence come for imaging and fibrosis markers? So you're all, I'm sure, very familiar with the PUSH study. This was a seminal work looking at imaging in children with CF. This was a prospective multi-center study in a large cohort of children ages 3 to 12 years. The study looked at baseline ultrasound patterns in this population and followed the ultrasound patterns over time, comparing these to biochemical markers. So in the figure on the right, each square represents a biomarker, while each color represents an ultrasound pattern, with normal being turquoise, heterogeneous green, nodular purple, and homogeneous being coral. For making this easy, we will focus on actually the means of these biochemical markers, with the black dot representing the average value, and I overlaid a dashed line to show the average normal value a bit more clearly. So as you can see across most of these biomarkers, the averages of all of the biomarkers are increased in children who have abnormal ultrasound patterns compared to the normal ultrasound patterns. Again, that's going to be in the turquoise. The exception is platelets, which is, the inverse to this is we would expect in clinical liver disease. So these next few slides show a sampling of literature over the past 5 to 10 years, and these papers highlight the emerging importance of imaging and fibrosis indices as markers for liver involvement and form the backbone of the liver guidelines. So this first paper was notable for revealing correlation of liver biopsy and fibrosis markers, particularly APRI score. The second paper compared ultrasounds with other important clinical correlates and found that abnormal ultrasound correlated with several factors, including impaired glucose tolerance and CF-related diabetes. Next, in the systematic review of pediatric and adult patients, the pediatric subgroup analysis identified APRI and liver stiffness measurement cutoffs for diagnosis of CFLD and found that combining liver stiffness measurement with fibrosis markers led to better sensitivity and specificity of diagnosis. Now, these two papers were extensions of the PUSH study, with the first being an interim analysis of the PUSH cohort. It showed that a heterogeneous pattern on initial ultrasound led to a 9.1-fold increase in incidence of nodular ultrasound on follow-up. Tobin's study performed quantitative MRI in a cohort of patients from the PUSH study and found that those with nodular ultrasound pattern had higher stiffness measurement in MRI than normal or homogeneous ultrasound patterns, while homogeneous livers tended to have a higher fat fraction on MRI. So now that we know all of this, how do we approach screening in pediatrics? So before we fully delve in, it's very important to understand that there's been a nomenclature shift in how to discuss liver disease in cystic fibrosis. While before we had multiple definitions of CFLD, as seen in this table, the new guidelines suggest 2 buckets of liver disease. So this graphic, which I borrowed from my colleague, Dr. Sate, notes the 2 buckets being CF hepatobiliary involvement, or CF-HBI, and the other being advanced CFLD, or advanced CF-HBI. This new nomenclature is important as it dictates how we will monitor and treat liver issues in children with CF. The disease states falling under advanced CFLD include having nodular liver, advanced fibrosis, multilobular cirrhosis, and portal hypertension with or without cirrhosis. Other hepatobiliary manifestations will fall under the category of CF-HBI. So now, moving to the meat of it, into the guidelines themselves. So as you know from an earlier slide, these guidelines are separated into screening, evaluation, and management. The image on the left is from the guidelines, and so that's actually in the paper. And then the text on the right highlights the recommendations and also some of our center's individual pediatric interpretation and practice. So as long has been the case, screening recommends annual physical exam and annual labs. Now there's also the addition of imaging, including the spleen, starting at age 3 years and every 2 years thereafter during childhood. In our center, we focus on having a gastroenterologist doing an exam at least once per year, calculation of fibrosis indices, baseline and follow-up ultrasounds that include the spleen and elastography, and an annual point-of-care transient elastography that we do in clinic. So with evaluation of CF-HBI, it's important to assess for other causes of liver disease, whether those are infectious, endocrine, autoimmune, or metabolic, with special attention to alpha-1 antitrypsin deficiency. Advanced imaging such as MRI may be considered when assessing for structural abnormalities, especially with cholestatic presentation, noting that children with CF rarely have cholestasis related to their CF outside of that neonatal period. In pediatrics, alkaline phosphatase elevation is often considered normal as part of growth. So if elevated, this should be kind of checked within the context of the patient's age, growth status, vitamin D, their DEXA, and other patient-relevant factors, rather than assuming it's a harbinger or a sign of cholestasis. So during this evaluation, you will decide if your patient has a healthy liver, CF-HBI, or advanced CF-HBI. Our center prefers that CF-HBI patients CGI at least every 6 months, and with advanced disease every 3 months or more often if indicated. So once diagnosed, more frequent lab work is necessary and should include CBC to screen for hypersplenism and portal hypertension, in addition to PTINR and albumin to assess synthetic liver function. Fibrosis indices are recommended. In our center, we typically calculate these between 2 to 4 times per year. In CF-HBI patients, we do annual or biannual point-of-care transient elastography, and we do annual shear wave elastography in radiology, so usually via ultrasound. We use modified dosing for modulators or other medications if needed. And for patients with CF-HBI on modulator therapy, we will obtain liver labs more frequently to assess for drug-induced liver injury. So in addition to the monitoring I already mentioned, something new is an earlier OGTT is now recommended. This should occur at time of diagnosis of advanced CF liver disease. Endocrinology and dietitians are important here for obvious reasons, but especially because we may see a rising number of children with newly diagnosed impaired glucose tolerance. With advanced liver disease of any type, hepatocellular carcinoma monitoring is recommended. Screening for HCC should include an annual alpha-fetoprotein and an ultrasound, which you're already going to be doing these very regularly. Monitoring for AFP is, of course, less common in pediatric settings, so it will be important moving forward and should be integrated into your screening algorithms. And as for patients with portal hypertension, the guidance is to follow the double ASLD and Baveno guidelines for monitoring GI bleeding. In our center, we do not use endoscopic surveillance routinely as primary prophylaxis for bleeding, but we do scope children who are under consideration for gastrostomy placement, as we want to avoid gastrostomy in children with varices due to risk of bleeding. So when to do liver biopsy? This is always the $1 million question, and unfortunately, we don't have consensus still. As you all know and are very familiar, liver disease in CF is considered to be patchy, and liver biopsy has not been considered a gold standard, which is why we have such an interest in imaging and fibrosis indices. Well, liver biopsy could be useful in distinguishing cirrhotic versus non-cirrhotic portal hypertension. This should be considered on a patient-by-patient basis due to the morbidity of liver biopsy and potential that it may not actually change your clinical management. So therefore, our practice has generally been to consider liver biopsy only in cases of unexpected or persistent liver marker derangements, suspicion for other liver diseases that have not been diagnosed biochemically, and or considerably abnormal labs or physical exam findings while considering modulator therapy. So treatment. Unfortunately, treatment is still elusive for hepatobiliary manifestations and cystic fibrosis. Years ago, UDCA was often used, but is being used less frequently as its use has not proven to be beneficial. There are, of course, selective situations where we may use it in pediatrics, however, such as in comorbid liver disease like biliary atresia, or there may be other things that you would discuss with your gastroenterologist. And as Dr. Narkowitz discussed yesterday, the outcome of modulator therapy on the liver is still uncertain, and therefore there are no current recommendations to use modulator therapy to prevent or treat liver disease. When possible, the focus should be on maintaining good nutrition and prevention of other liver diseases via vaccination and maintaining a healthy BMI. And although it is not yet known if there's a benefit to modulators, modulators are not contraindicated in patients with compensated liver disease or in those with liver transplant, although the consensus guidelines does recommend against modulator therapy in decompensated liver disease. So for those with portal hypertension, management should be on an individualized basis and based on those aforementioned guidelines. If considering prophylaxis for variceal bleeding, gastroenterologists should work with pulmonologists on the safety and utility of non-selective beta blockers or serial endoscopic surveillance. If clinically significant portal hypertension, teams should consider portosystemic shunt or liver transplant. And lastly, if your patient has advanced lung disease and liver disease, consider a lung-liver transplant evaluation. So in conclusion, we know more now than we did before. Ultrasound and fibrosis markers are going to be your new best friends, so definitely get used to those. And although there are still many unknowns, particularly as new therapies emerge and our patients live longer, we will have much more to study, and there is a lot of excitement in the GI and hepatology world with cystic fibrosis. And so finally, in the words of American philosopher William James, is life worth living? It all depends on the liver. So. Okay. Yeah.
All right. Our next speaker is Dr. David Assis. Dr. Assis is an assistant professor of medicine in the section of digestive diseases at Yale School of Medicine. He is a practicing hepatologist, and his clinical and research focus center on autoimmune and cholestatic liver diseases, as well as GI and liver manifestations of CF. He was a past recipient of the CFF Digest Award and is closely integrated into the adult CF team at Yale. He will be presenting new CF liver guidelines, implications for adults with CF. Welcome, Dr. Assis.
Thank you so much. Thank you very much for the opportunity and for the organizers, the chairs, and the fellow speakers and the attendees. It's a pleasure to be able to speak to you today, especially to follow such a nice comprehensive discussion of the guidelines from a pediatric perspective. I think in order to try to minimize the overlap, I'll give you some observations that might be relevant to adults, and we'll kind of take it from there, and we can answer further questions when we have the open forum at the end. No disclosures. Okay, so with regard to CF in general, I think this audience doesn't need any reminder whatsoever of the fact that we are living in an extremely exciting era with regard to outcomes, survival, quality of life, things that were really unimaginable 30, 40 years ago. And I'm sure many people are familiar with this type of graph showing that there are now many more adults with cystic fibrosis than children. That's obviously something that everyone should be congratulated on, and we're going to carry this forward. As you can also imagine, it means that that we're in uncharted territory when it comes to how the burden of organ damage from cystic fibrosis will manifest in the decades to come. With regard to the liver, then, you can imagine the scenario from this Science article, of course, when CFTR was cloned and the subsequent survival of that kid shown again in 2009. The real question, of course, will be what will happen to the liver of these individuals as they age, and particularly in middle age and beyond. We really don't have large experience with this, and so I think we need to be cognizant of the territory that we're moving into. Part of the reason I bring this up, just for this audience, is that we are starting to learn a little bit more now about the burden of cystic fibrosis in adults. This very nice article from some colleagues in France looked at over 3,000 individuals born after 1985 and found that there was an increased incidence of about 1% per year in the diagnosis of CF liver disease, with a cumulative incidence of up to 33% at age 20, 10% of which had actually advanced portal hypertensive complications. Furthermore, here in the United States, for example, some colleagues of ours at the NIH who looked at 36 patients for over 25 years who did not have CF liver involvement at the time of entry into the study. Depending on the criteria for the diagnosis, anywhere from a quarter to a half of them ended up diagnosed with CF liver disease, and that continued even after the age of 20. Furthermore, those who had cystic fibrosis liver disease and who died, regardless of the cause, had a reduced platelet count. And although that's been a suggestion and association, it does raise the concern that underlying portal hypertension could be further causing a stress or impairing the body's ability to heal from other conditions. Therefore, I think the guidelines, which were initially introduced in the last speaker, are very helpful to help zoom in on how we can affect and make a positive change in prevention diagnosis for adults with CF. So I'll just go through a few of the, obviously there's not time to go through all the statements, nor is that relevant for this discussion, but I'll try to highlight some areas that might be relevant for adults. First of all, I think as was already mentioned, annual labs should be performed at a time of clinical stability for the identification of hepatobiliary involvement. And of course, I think we can all recognize that as we age, there are many more issues, many more medications, many other conditions, some of which we have nothing to do with cystic fibrosis. And so I think the time of clinical stability has extra importance and should be assessed carefully in the context of adults who have CF. Furthermore, there was a very nice discussion, Dr. Lazar, about the ultrasound to examine the liver and spleen every 2 years. Fortunately will not be going through the PUSH study because that was very nicely showed. But if you think about that, that was specifically for pediatric range. And so the consensus from the committee was that we do not have enough data to continue to suggest that in perpetuity for adults. Therefore, if there's a baseline screening, which is recommended, the optimal frequency of subsequent imaging, I think, needs to be further studied. And so from a practical standpoint, I think one could surmise that repeat imaging, if there's any clinical change or a new elevation of liver enzymes, would be reasonable. Next, the implication of baseline liver elastography. I think this was discussed very nicely by Dr. Lazar. Just for those who are not familiar, this has become standard in academic hepatology around the country to have non-invasive measures of fibrosis with this brief test that gives a measure of stiffness. The guidelines do give what's known, at least in terms of the ability to have thresholds that would indicate more advanced fibrosis. For example, with a kilopascal, which is the unit of measurement, greater than 8.7 can be ruling in more advanced disease. And I think of all the measurements, or the modalities, I should say, to study this, transient elastography is by far the most studied and also probably the most available at academic hepatology offices. So it's something that I think the CF community will become more and more familiar with over time, because that's part of our routine toolkit in hepatology. Next, I think there was a nice discussion just now of the need to have a standardized evaluation for other causes of liver disease. And you can imagine, of course, that'll vary based on your patient population, but also on the age. I think with the obesity epidemic, of course, in the United States and worldwide, you might find much more steatotic liver disease. Chronic viral hepatitis becomes important, obviously overuse of alcohol, and polypharmacy. Let's face it, as people get older, there will be more and more medications, some related to CF and some not, as well as herbals and other supplements. As an illustration of what ALT can sometimes tell us and may not be telling us, this very nice study from 2019 looked at adult men with cystic fibrosis and found that the ALT was more elevated in those individuals who had greater glucose intolerance or glucose OGTT elevations and hemoglobin A1C elevation. So in some populations, an ALT elevation might be telling us about CF-related diabetes. And so we have to be aware of this and put it into context. Furthermore, there was a discussion of the liver fibrosis indices, such as APRI, for example. In this study, which I had referenced a few minutes ago from the NIH, in the individuals who developed adult onset of CF disease of the liver, you can see that the platelets were dropping. And as was discussed, this is a measure of portal hypertension by hypersplenism. And so we can learn a lot from a decrease in platelets over time. Furthermore, the APRI is the most studied and validated, at least in the context of CF. This study also from the NIH showed the correlation between the APRI test and the transient elastography or the FibroScan values. You can see it in the adults who had greater than 6.8 kilopascals, indicating more fibrosis. The APRI score was elevated. So these are talking to each other, these two values, and which we can make use of in clinic. I think despite the fact that larger populations need to be studied, APRI is by far the most well evaluated in CF and probably the best one for calculation to identify advanced CF liver disease. The PUSH study was already referenced, and of course you can see on this graph or these representative images to the right the differences between normal, a heterogeneous, homogeneously abnormal, and of course a nodular liver. I think the ultrasound should be performed every 2 years once you have the diagnosis of CF liver involvement. So just to be clear, any age, no matter whether you're pediatric or adult range, you should continue with these ultrasound-based monitorings. The discussion of what to do with prevention and therapy for varices, I think bears some qualifications when it comes to adults. There is not impossible, but less likely to be a concern for reactive airway disease in adults unless the lungs are severely impaired. So we are a little bit more comfortable with non-selective beta blockers in adult populations, although of course this should be individualized. The guidelines recommend referring to the AASLD and the Bovino group, and of course one would have to then pull that up and look at it, which is reasonable because it's outside the scope of the guidelines, but I'll just give a snapshot into what they reference. This is the nice guideline from the AASLD with regard to what we're talking about. And if you look here at the graph or the cartoon, you can see that liver stiffness as measured by transient elastography and the platelet count are highly related. As you get into a more advanced disease, we will have greater stiffness and a reduced platelet count, and that is the population that we're trying to target to prevent complications such as variceal bleeding. The recommendation then from the AASLD is to start non-selective beta blockers such as carvedilol in patients who have clinically significant portal hypertension to prevent decompensation. But despite what I just said, there will be individuals, of course, who are not able to sustain the beta blocker therapy. And this is where the Bovino group, I think, has helped us in general in hepatology. You can see this very nice recommendation here for patients with compensated cirrhosis who are not candidates for initiating non-selective beta blockers. They should undergo an endoscopy for variceal screening if the stiffness is greater than 20 kilopascals or the platelet count is less than 150. That then can obviate the need for routine and unnecessary upper endoscopies, especially for patients who have some degree of pulmonary compromise. And so you can obviate that in those patients because this group of patients then would have a less likely, reduced likelihood of variceal bleeding. Of course, then if you do obviate the upper endoscopy, you should recalculate and assess that on a yearly basis. Concluding then, I think it was discussed that, of course, liver cirrhosis can increase the risk of cancer, and although that probably will still remain, fortunately, rare in pediatric populations, it will become less rare as you age, and I think we should just always impart on all of our patients that regardless of the etiology of cirrhosis, as one gets older, ultrasounds and alpha-fetoprotein should be performed every 6 months. I think that's a very strong recommendation. The liver transplantation, then, we'll just conclude with this of a few unique considerations for adults. I think it's very clear to most in this audience that if you have decompensated cirrhosis with liver failure, liver transplant should be considered. That's in the guidelines. What are some considerations for adults? Well, I think there are age-related comorbidities that are probably less relevant for pediatric populations, such as the impact of long-standing kidney disease. Many of our adult patients need dual liver and kidney transplants, something that's probably less likely to occur in pediatric populations. Obviously, dual liver lung transplants will be increasingly necessary to discuss based on the effective ETI and the anticipated course of lung disease, not just in the pediatric range, but for decades to come in adulthood. Cardiovascular risk assessment, that's the biggie for any transplant evaluation in adults. And given the metabolic and the systemic effects of CFTR and the medications, it's going to be increasingly important for us to be very clear on those risks in the transplant setting. And of course, the long-term impact of CFTR modulators, which was already discussed. We have these scenarios occasionally where the lungs are improving, but the liver is declining, perhaps as a result of ETI, and how that plays out in adults is going to be very important. And then lastly, nutritional considerations. We have, unfortunately, in adult patients, this concurrence of obesity, sarcopenia, and frailty, and how to make that work as we get older is going to be increasing need for us. So where are these patients coming from and the implications for these guidelines? I think patients, or at least adult patients with CF liver disease might be coming to us from the transition clinics, from GI and hepatology. They might also be coming with known CF, but be in an adult CF program with the first manifestation of liver disease as in adults. And so we have to be aware and mindful and screening for that. Furthermore, though, we're increasingly seeing newly identified cases in the community being seen by GI and actually no known diagnosis of CF. So we have to be aware of the multiple ways in which patients can present and be able to handle that quickly. I think there's a need for expertise in hepatology and CF, clinicians and team members with experience in chronic liver diseases, and for centers that may not have that built-in expertise, I think the Digest Network is a ready-made and very valuable resource which can be explored. So in conclusion, I think the new CF guidelines are moving the field forward, as was discussed by Dr. Closar. I think we need to increasingly focus on the burden of CF liver disease in adults because we really don't know how this will play out in the decades to come. Key needs that can be addressed are implementation of the guidelines. I think that'll be discussed by an upcoming speaker, a research agenda to help outline priorities, and really the development of therapies to prevent and ameliorate CF liver disease in our adult patients. And with that, I'll thank you for your time.
Thank you.
Coming up to the podium right now, our next speaker is Zubaida Aslam. She's a fourth-year medical student at UT Southwestern Medical Center. She completed her undergrad degree in biology and health and society at Southern Methodist University in Dallas, Texas. She's really interested in pediatric gastroenterology and has been working with, and I'm so jealous, Dr. Meghana Sateh. Okay, I want to make sure I pronounced that right. In the Cystic Fibrosis Clinic at Children's Medical Center, Dallas.
Perfect. Hi, everyone. Thank you so much for being here for this session today. I'm incredibly grateful for the opportunity to be here and to present. And today I'll be presenting a quality improvement project we began at our center meant to harness the EHR in order to implement the new CF liver disease guidelines. And then I have no disclosures related to this presentation. So this project was implemented at the Dallas Children's UT Southwestern Cystic Fibrosis Clinic, which serves a large catchment area of North Texas. We currently have a total clinic population of 286 people with cystic fibrosis. Our clinic is co-directed by a pediatric pulmonologist and gastroenterologist, and we have 3 dedicated pediatric GI physicians that see about 80 to 85% of all patients in the CF clinic. In addition, these GI physicians also attend our weekly patient review where the entire CF clinic team is present and discusses all patients that will be seen in clinic the following week. Next, I would like to give a couple definitions that I think will be helpful for our presentation. Our project focused on the utilization of 2 specific EHR tools to help with implementation of these new liver disease guidelines. The first is a smart phrase, or also known to some as a dot phrase, and this feature allows you to insert text or data into a clinical note. On screen is an example of a smart phrase we used in the past to insert liver labs into a note and prompt a provider to enter their exam, imaging related to liver disease, and other workup. Smart phrases are easy for anyone to create and are easily shared amongst users. However, they are not extractable except by chart review and are not saved in a patient's chart across encounters. However, smart forms are a slightly more advanced clinical workflow tool that can be carried across encounters, are extractable and comprehensive, but they're a little more difficult to create. These tools are embedded in the patient's chart. Our CFGI team has used these EHR tools in various ways over the years for liver disease monitoring. The first tool was a smart phrase created in 2014, as was seen on the prior slide. In 2020, we created the first smart form design implemented in our clinic and began using a best practice alert tool to remind providers to order an abdominal ultrasound if liver labs were abnormal. In 2022, we began a QI project utilizing transient elastography as part of CF-related liver disease monitoring. And finally, this past year, we have decided to start a QI initiative directed at implementing the new guidelines and CF-HBI classification system. For this project, our global aim was to implement the standardized classification of hepatobiliary manifestations in persons with CF for improved outcomes in screening, monitoring, and management of hepatobiliary disease. In order to create a more quantifiable and tangible goal to do this, we created our first SMART aim to increase classification of hepatobiliary manifestations in persons with CF from 0 to 25% by June 30th. But this then rose the question, how are we going to do this? So we started by assessing our current process for monitoring for CF-related liver disease. Next, I'll show a process map we created in March of this year that was a reflection of our current process of monitoring for CF-related liver disease prior to any interventions. Patients at this time would obtain annual labs and possibly annual transient elastography and be scheduled for at least an annual GI visit. The patient would then be seen by a GI provider in the CF clinic. During that visit, the GI provider would then utilize the smart form that was created in 2020. Given the labs and clinical assessment, the GI provider would then classify the patient as having CF-LD or not. Then, based on this classification, the GI provider would determine what labs and imaging needed to be ordered, such as transient elastography, ultrasound, and then determine when next follow-up would need to be. This process may sound simple enough, but we are all too familiar how this is never usually the case, and there's many pitfalls along these steps. So in order to find the best interventions that improve our current process, we created a QI tool known as the key driver diagram. This tool consists of the major factors we determined would most impact the ability to achieve our SMART aim. Our 4 key drivers included knowledge regarding new CFLD guidelines, methods to classify patients in EPIC, which is our EHR, ensuring that annual labs, transient elastography, and ultrasounds are being completed, and ensuring awareness of the new classification system throughout the CF team. We then brainstormed several interventions meant to achieve these key drivers. Some of these we've completed, shown in blue. Others are ongoing, highlighted in green, and others are some of the future interventions shown in the white box on the right. In the next few slides, I'll review our PDSA cycles to discuss these interventions in more depth. For our first PDSA cycle and intervention, we decided to create a SMART phrase, shown here. The SMART phrase prompted providers to classify patients per the new CF-HBI classification system, as well as identifying if the patient had advanced CF liver disease within their clinic notes. We started with the SMART phrase since it could be made easily and implemented quickly. Once the SMART phrase was created, it was first used by a single GI physician in clinic on March 28th. Once our first GI provider was comfortable with the SMART phrase, we then trained the second and third GI physicians in our clinic. By April 18th, all 3 GI providers were utilizing the SMART phrase. After utilizing feedback and experience from SMART phrase usage, we continue to work on the new SMART form that would integrate all the new classification system, as well as labs, imaging results, and predictive scores such as APRI or GPR. And on July 15th, the new design of our SMART form was complete and it was able to go live into our EHR. So this slide shows a screenshot of the new SMART form we created. As you can see, this is a much more comprehensive system than just the SMART phrase we had been utilizing before. With the SMART form, we incorporated physical exam findings such as splenomegaly, as well as the most recent set of labs and imaging related to liver disease. This form also calculates APRI, GPR, and FIB4 scores automatically based on the labs incorporated. We also added a feature that turns boxes yellow or red for set scores to indicate to providers that the score was elevated. This slide shows the second part of the SMART form, in which we incorporated the CF-HBI classification system. And this new design included the cutoffs for each category to assist with classifications. For example, for stiffness of liver, we included measurements that would qualify for elevated stiffness from both transient elastography or ultrasound elastography. The SMART form then automatically creates a CF-HBI score, and then the provider can select a CF-HBI or advanced CF-related liver disease based on the score that was calculated. And on screen is a QR code to a PDF which summarizes all of the EHR tools that I've explained and that were utilized in our CF clinic. After tracking utilization of the SMART phrase and SMART form from March 28th to August 2nd, we decided to see if we met our original SMART aim of screening 25% of clinic patients by June 30th. This graph represents the cumulative percentage of total patients screened with our CF-HBI classification tools. Date is noted on the x-axis and cumulative percentage on the y-axis, with important dates from our PDSA cycles noted. So we were very, very pleased to see that we had actually met our goal earlier by mid-May. And by August 2nd, we had screened 40.6% or 116 of our CF clinic patients at least once for CF-HBI. Of the 116 individuals screened, we found that 44 patients or 37% qualified for CF-HBI. And of those with CF-HBI, we found that 10 patients or around 22% had advanced liver disease suspected to be related to cystic fibrosis. The remaining 34 patients with CF-HBI did not qualify for advanced liver disease. Ultimately, when comparing this to our prior process and methods, we found a substantial improvement in detecting patients with CF-HBI. Prior to our interventions, 19 patients in our CFF registry report were noted to have CF-related liver disease. However, we didn't have any easily trackable records to understand what manifestations of liver disease they had, and certainly did not have any CF-HBI classification data. However, after implementation of these new tools, we've already found 44 patients that qualify for CF-HBI and 10 that have advanced liver disease. This represents a significant improvement in identifying patients with hepatobiliary involvement, and with better recognition will lead to better monitoring and assessment of progression. We did come across some limitations during this project that have also helped guide future directions. First, we were hoping to have other non-GI providers utilize the SMART form, but initially it was only accessible under the gastroenterology context. We have worked to now allow access in other contexts as well. We also found during this process that we could not access the SMART form during pre-charting, which we are now working to change. Additional next steps include creating an educational tool for families to provide more information on the new guidelines. Lastly, we're tracking the results of our screening to help direct future QI projects. We're very excited to see how these changes will lead to improvements in care for people with CF in our clinic, and hope that you found this helpful and maybe provided some ideas for your clinic as well. Please stop by Poster 817 if you have any questions or would like to discuss more or see any of the tools that we used. Lastly, I wanted to say a sincere thank you to our entire CF team, especially the names listed on this slide, for their constant support and for embracing this project. Your dedication and collaboration have been vital to its success. And I lastly also wanted to say a special thank you to my mentors, Dr. Sate and Dr. Podorf, who graciously supported me throughout this project and made it possible for me to attend this conference and present today. So I'd be happy to take any questions.
Excellent job, Zubeida. Thank you for coming.
All right, our next speaker is Dr. Michael Hook. Dr. Hook is a gastroenterology fellow at Children's Hospital of Los Angeles, currently a PGY6. He is primarily focused in general gastroenterology, and his interest in patients with CF is part of a growing need for pediatric GI involvement in CF care. He states that he feels very honored to present, and he owes a lot to his fabulous faculty at Children's Hospital of Los Angeles, both in GI and Pediatric CF Care Center. He will be presenting abstract number 811 entitled Identifying Gaps in Cystic Fibrosis-Related Liver Disease, Comparing Current Practices with the New Guidelines. Welcome.
All right, thank you so much for that introduction. Really happy to be here. So like we had said, my abstract was focused on looking to see how current clinical practices in our CF Center at CHLA compared with the newly released guidelines to see where we could find areas of improvement for better implementation. Disclaimer slide, I don't have any disclosures for this talk, thankfully. Some key terms that we've really already gone over, we probably can skip over these since we've already discussed these in detail. So the new guidelines came out, hooray. But the question always comes up, with new things, how well are we actually doing right now in our current clinical practice? To try and answer this question, we set out for really 4 objectives, starting off with first accurately classifying the presence and degree of hepatobiliary involvement, really to try and apply the appropriate guidelines to see how we were doing. Once we had done that, looking at where we were doing well, where we were not doing as well, and see where we were having gaps in our screening and management. After finding the gaps, seeing where the barriers to implementing these guidelines appropriately were and why they were happening in the first place, and ultimately to provide recommendations to our clinicians. So first we had to see how do people fit into the new classification scheme for CF-related liver disease. We first took all of our patients in our EMR review who did not have any diagnosis of CF-related liver disease, which was about 91 patients, and then applied the 2024 definitions. We came out with actually 20 patients who had not been previously identified of then being meeting the criteria for CF-HBI, so about 1 in 5 actually did carry a diagnosis that would change how we're screening and monitoring these patients. Thankfully, no patients with advanced CF liver disease here. And then looked at all the patients who carried a diagnosis in the EMR of some form of CF-related liver disease, finding that most fell into the CF-HBI category, and we had 1 who was advanced CF liver disease who was thankfully already fairly well recognized based on their degree of hepatobiliary involvement. And interestingly, 4 of these patients did not really meet the criteria for CF liver disease any longer. And the patients who were identified here previously had elevated liver enzymes that had since normalized, or maybe an abnormal finding that had since normalized in subsequent imaging. For the patients who identified previously to not have any full liver disease who now qualify for CF-HBI, most of the time they had an abnormal liver ultrasound finding or some kind of change in their liver enzymes had not really been totally identified yet. So a fair number of patients identified in total of our 119 patients that we see, and now 43 qualify for CF-HBI, and we had our 1 who is now classified as advanced CF liver disease. So after doing that, we then went through all the applicable guidelines for each category and then saw the applicable screening, monitoring, and treatment goals for those patients to see how do we stack up based on what we're currently doing. For the patients who did not have any evidence of CF-related liver disease, most patients were getting labs, most were having an exam, everyone's having an exam, but specifically having a documented hepatosplenomegaly exam was something that only about 1/3 of patients actually had documented. When talking to our clinical faculty, most were doing this exam, but actually documenting it in the EMR, whether that's not part of a template or something that they didn't necessarily put into their documentation for tracking was one of the ways that we found that this gap was happening, although most were getting this exam. Imaging, specifically ultrasound imaging, many had some time in the past, but in terms of the new guidelines where more frequent ultrasound imaging is now being recommended, this was only happening in a minority of patients, likely reflecting how much more frequently this imaging is now being sought for these patients. For the patients who qualified now for CF-HBI, we had a similar connection with labs and exam, but specifically a hepatomegaly exam and the liver-specific exam, saying the contour, the size, nodularity on these exams were, again, not necessarily being documented as frequently as we wanted to. Most folks were comfortable with doing the exam, although that was something we discussed to make sure everyone was comfortable actually doing these maneuvers and felt confident in examining the liver on the abdomen, which is, if anyone's who tried to examine a child's abdomen, you know how tough it can be. But making sure it was actually being documented every time. In terms of screening, about half of the patients had some form of ultrasound at some point for screening, and at least half had elastography. These numbers are probably driven down a little bit by the newly identified patients that didn't previously have a designation of liver disease. And then for monitoring, you can see imaging was about the same. Most patients also had Doppler, but our elastography was very, very low. Only 4 patients were having monitoring elastography. We saw that the difficulty was in that actually getting that elastography required a gastroenterology referral, scheduling a hepatology clinic, and only was able to be ordered by a gastroenterologist, some pathway that we really had not really well defined for these patients. Because of those barriers, they simply weren't getting these, which was a major gap in terms of just at some point getting elastography rather than the regular interval imaging that's now being recommended. For screening, looking at alternative diagnoses were 9 different potential designations for other reasons outside of CF that could be looked for, but a third of patients had what we qualified as comprehensive screening. This is a little bit difficult because many had some degree of screening, but in terms of looking all of the things that had been recommended for alternative diagnosis evaluation, not all of them had that. And something that's a matter of discussion as to how to comprehensively do that while also being cost effective and kind of not going too far in a potentially very long lab evaluation, imaging evaluation. The last thing for our CF-HBI patients, and I know it's not a hard recommendation about ursodiol or UDCA, about 44% were not on ursodiol. I know right now it's not being recommended to start, but a matter of discussion as to how do we stop these patients and how do you individualize the usage of ursodiol and how do you talk to families about stopping a medication that many are very attached to and want to do something about it, even if it doesn't really have a lot of clinical evidence to back its use to prevent progression of liver disease and CF. And for completeness sake, our one advanced CF liver disease patient, thankfully, had already been very well identified and was completely connected with most of the things, unless it was not necessarily qualified for this patient. The one thing that did come up was a fibrosis index. You might have noticed on the last slide that fibrosis index was none of the patients. It's something that simply wasn't on our radar when we were looking at these things. When I was reviewing the guidelines, I couldn't find anywhere that we were utilizing any of the options. I would love to talk afterwards for which one is preferred by folks who already have these in regular use, since it doesn't seem like one is favored over another. So please find me afterwards with that. I would love to talk to you about it. So after identifying some of these barrier gaps, how did we try and go about bridging these gaps? We kind of divided them to simple and more complicated things, not that they're difficult, but easy fixes versus maybe ones that need some more discussion. For exam findings, it was really a matter of documentation, saying we need to make sure that we are documenting what we're actually doing, even though it takes a little bit of extra time, which is difficult in such a comprehensive clinic as most of our CF clinics can be. These encounters are long, and additional things for documentation make the documentation long. In terms of imaging, ultrasound is something that thankfully is readily accessible for us in most places, but the path for elastography and ensuring that we had someone to review this and actually having a pathway for these patients, one of the things we are paving the way for right now to ensure appropriate monitoring. And the fibrosis use index, we already talked a little bit about that right now. I call these other two things complicated because the evaluation of alternative diagnoses, like we said, can be a very large pathway in terms of what labs need to be drawn and what imaging and review need to happen. I think it's something that we need to more discuss about how to cost effectively but comprehensively evaluate these patients when we may have a difficult idea of what exactly might be causing liver enzyme elevations, changes on ultrasound findings, how to nicely refine that for each patient while not doing too much. And then ursodiol use, especially talking with families about discontinuation, which is largely what is favored right now for patients who don't have any form of cholestasis. I think that can be a difficult conversation. So what recommendations have we provided thus far? And this is an ongoing process, so bear with me, we're still working on these things. We kind of had practitioner focused and then patient focused interventions. The practitioner focused ones were first just making sure everyone was aware of the guidelines, what is appropriate to be doing at different stages, and making sure we had people clearly identified into what category they fell into with continuous updating as we got more information per patient. We also made sure to have close discussion for reviews of barriers to actually getting these things done, which I think is an appropriate thing for all clinics to do. The other thing we try to implement is template implementation. We all know that new guidelines add more things to an already packed visit for complicated patients. So adding more things can give you a real headache, especially when you're seeing the patient with so many people and trying to document. To try and take some of that burden off, we try to implement things individualized for non-CF liver disease patients, CF-HPI, and advanced CF liver disease, both for tracking and for monitoring, just to remind you to do it and minimize the amount of burden that it takes to document and update that documentation. The patient-focused intervention we've done so far are actually educational pamphlets, both in English and in Spanish. I think when you see families and you start doing more things or new things, there's always a question of, why aren't you doing this before? Why are we doing this now? It can be a difficult conversation, and having this as a preface to new things that might be recommended really hopefully puts a lot of our families at ease in saying, we are up to date, we're making sure to do these things and get them used to what might be changes in their child's care to be a bit more comprehensive than we were before. So that's what I have. I really appreciate your time, and thank you so much.
Our next speaker is Katie Clemens. She's the adult clinic coordinator at Northwestern in Chicago, Illinois for over 5.5 years. She is deeply committed to advancing the program's quality improvement initiatives and enhancing system efficiencies. Her efforts have focused on driving the successful implementation of QI processes and continuously updating and optimizing the clinic's operational systems to improve patient care and outcomes. She is presenting abstract number 768 entitled Implementation of Cystic Fibrosis Foundation Guidelines for Screening, Evaluation, and Management of CF Hepatobiliary Disease and Impact on Patient Care.
Thank you, Christy and Darcy. I'm glad you said it, not me. It's a long one. I have nothing to disclose for this presentation today. So objectives for this morning's discussion will be to describe a clinic-specific standardized protocol for CFLD screening driven by the RN and PharmD, show results of our implementation, recognize possible barriers to implementation of CFLD guidelines, and nurture a culture of staff-driven QI and other scholarly initiatives around the CFLD guidelines implementation at your center. So this picture is the published CFLD pathway. I know it's difficult to see, but this is, like I said, in the published pathway. So the way we interpreted it is, and what I want to point out is in the blue is kind of the CF clinic's responsibility, and then as abnormalities were more identified and we got kind of in the muck, the yellow part was when we needed more of the hepatology specialists or the GI specialists to kind of get involved and help with recommendations and more of that scoring. So this is how we created a more easily readable and understandable algorithm for our clinic. So we took those guidelines and simplified them for a 3-track, just like the published guidelines, the yellow path being for the labs, the LFTs and the GGT, and then the green is the ultrasound, the right upper quadrant ultrasound for fiscal responsibility to our patients. We also data mined for our patients for CT abdomen with contrast, MRCP, and MRI abdomen. We wanted to make sure that these data mines included patients, or these imagings were done after the patient turned 18, because we are talking about the adult clinic, at least in our case, and they were a part of the adult clinic when these were completed. And then the purple track were for the hepatos and splenomegaly, or the palpation of and documentation of. And then the second track follows, I try to color them the same way as the published guideline, follows the pathway down for abnormal findings. And so the blue was more of the cystic fibrosis clinic responsibility. And then in our case, we did have a hepatology resource. So that was kind of his responsibility, but you can also use your GI resources if you don't have access to a hepatologist in your center. So basically in this case, how we did it is we had an abnormal finding identified, and we would send a bi-monthly email to our participating hepatologist for asynchronous hepatology chart review. And then recommendations were made by him, and then an email would send back. So it would be a batch of patients sent to him, and then a batch of patients with recommendations sent back to us. And then the CFRN, which would be me, would enter all of the orders and the referrals into the EMR. And then our PharmD would contact the patients, discuss the orders, the plan of care, and answer any of the questions or concerns they would have. And then we would continue to use the published pathway for any ongoing follow-up or plan of care that we needed beyond those points, or when we would get these recommendations back. So results. So our pre-interventions, we surveyed our providers, which included 3 physicians and 1 APRN, and we found that 10 out of 165 patients in our population, 6% with had known CFLD. Over the following 10 months, 96 out of the 155, which would be minus the 10 known, had 62% of our adult CF clinic were screened. And 39 of that 96 screened, 41% had imaging or LFT abnormalities that were sent for asynchronous hepatology chart review. And 17 were asked to be seen in the hepatology clinic or asked for a further referral to the hepatologist. Abnormal imaging was found in 35 of that 96, and that's 36%, which drove the positive findings more than abnormal LFTs, which was 8 out of 96, or only 8%, which was previous guidelines. Only 4 patients had isolated LFT abnormalities. The rate of newly ordered ultrasound with reports of hepatobiliary abnormalities was elevated at 38%, or 18 out of 48. So conclusions from our data. Ultrasound results drove the abnormal screening results for our cohort rather than labs. Other abnormal imaging included features found on recent ultrasounds, CT abdomen with contrast, MRI abdomens, and MRCPs, and these imagings were agreed upon with our hepatologist. We just didn't decide on these. And this adapted algorithm for RN and for PharmD implementation increased our CFLD population from T, which was pre-implementation, from 10, which was pre-implementation, to 59 post-implementation, which is an increase by 490% in our cohort. So what we learned. Limitations, so palpation of the liver and spleen in CF clinic. Not one spleen or splenohepatic abnormality was identified on palpation in our clinic by a provider. And the bandwidth of designated personnel responsible for managing orders, results, and referrals is a critical consideration. The implementation of a 3-track pathway necessitates sufficient time for tracking, follow-up, and data interpretation. And identifying and engaging a hepatologist who is willing and fully collaborate and participate in the project possibly without any funding or financial compensation is essential and could be difficult to do. and organizing and tracking recommendations, results, orders, and referrals in a manner that is intuitive, where all can understand the data is crucial. We created a spreadsheet that we continuously updated, altered, and changed, especially at the beginning of the project, to enhance organization and clarity. It is essential that any modifications are thoroughly discussed, understood, and agreed upon by all parties that are accessing and utilizing that spreadsheet. So, pearls of wisdom from our clinic to yours. Developing a pathway optimized for the resources, time constraints, and scale of your clinic, ensuring it is both effective and well-suited to your operational context is important for success. Effective collaboration and communication with a hepatologist or gastroenterologist who is willing to work closely with the CF team is crucial for successful implementation outcomes. It is essential to schedule a meeting to discuss and establish communication protocols, including the methods, cadence, and channels of communication that work best for everybody. Additionally, having the hepatologist review or gastroenterologist review and provide input on relevant clinic pathways is imperative for ensuring comprehensive and coordinated care. And prepare for a higher incidence of hepatobiliary involvement among your patient population than initially anticipated, as indicated by our data and reports from other clinics nationwide, which could cause increased workload and workload on participating team members on your project. Thank you so much for the opportunity to speak. I want to thank the Northwestern CF Clinic, and please visit poster 768 for more information. The algorithm that was tailored to our CF Clinic is available on the handouts button for this workshop, and you can also email me for the algorithm that you can adjust for your team. And I also have docs, an Excel document that you can ask for as well via email. Thank you.
Thank you, Katie.
So our final speaker is Dr. Ala Abdelghani. Dr. Abdelghani is a third-year pediatric gastroenterology and hepatology fellow at the University of California, San Francisco. She has been awarded both the Cystic Fibrosis Foundation first and second year fellowship grant and the Cystic Fibrosis Foundation research grant. Her current research is dedicated to improving screening practices for cystic fibrosis-associated liver disease and utilizing implementation science to address gaps in these screening practices. She will be presenting abstract number 610, entitled Gaps Between New Hepatobiliary Screening Guidelines and Clinical Practice in Cystic Fibrosis.
Thank you, Darcy, for the introduction, and thank you for the invitation. I'm really excited to hear about all the good work from our colleagues, and I thank the speakers for sharing their experiences, and hopefully this will be a start of a collaboration between our centers for all this hard work you're doing. I will follow the same theme of looking at gaps and hopefully trying to implement the guidelines. So I'm excited to share our work at the Benioff Children's Hospital at University of California, San Francisco. I have nothing to disclose. As my colleagues mentioned, we have these new guidelines. It's been a year now and since they were issued, the first update after 24 years. To implement the new recommendations, we started with assessing our current practice to identify gaps and hopefully areas of improvement. In this study, we focused specifically on screening practices in people with CF and hepatobiliary involvement. So what is hepatobiliary involvement? In this study, we defined hepatobiliary involvement as persistently elevated AST, ALT, or GGT 1.5, the upper limit of normal, for age and sex for more than 3 months, and or abnormal liver imaging. And that's based on the East-Pagan-Naspagan paper from January 2024. The guidelines did recommend that all people with CF and HBI should receive a standardized evaluation for other causes of liver disease, and these are summarized here. So in our research, we answered this 3 questions to assess practice gaps in HBI evaluation between the current practice and the 2023 guidelines. Did people with CF who meet HBI criteria have medical records documentation? And did people with HBI receive the recommended liver evaluation? And what are the factors that affect receiving the recommended evaluation? So our objective, as mentioned, we identified practice gaps between the 2023 guidelines and the current practice in HBI identification and evaluation. Our hypothesis was that HBI might be overlooked if age-appropriate liver enzyme normative values are not used. This is actually important because we've noticed that, at least in our medical record numbers, that the normative values that are used are higher than the normative age and sex values reported by the Canadian study for pediatric values or pediatric intervals, and that was referenced in the guidelines. Our second hypothesis was that those who are on CFTR modulators are less likely to receive further liver-specific workup. So for our research, our primary outcome was receiving further liver-specific lab evaluation to identify other causes of liver disease. And we looked at multiple predictors. The top 3 were seeing GI outpatient, HBI documentation in the medical records, and the CFTR modulator use. For our methods, we did a retrospective chart review. We looked at all patients who were followed at our multidisciplinary clinic at the beginning of Children's Hospital, people from 0 to 21 years of age in the period from January 2017 to 2023. We included those who had at least 2 outpatient clinic visits. We excluded those who received a liver transplant during the study period, as their screening and monitoring is totally different. For our measurements, we did an automated data extraction for demographics, lab values and dates, and also visit diagnoses. We're happy to share the codes. We use Apex. We're happy to share the codes if other centers would like to collaborate. We did a manual extraction for ultrasound indications, findings, and dates. For our results, we identified 112 people with CF. 40% of these met HBI criteria, and as we mentioned as we defined earlier. So this table summarizes the demographics and the characteristics of people comparing CF and non-CF, comparing HBI and non-HBI group. We had racially and socioeconomically diverse group. More than 30% self-identified as mixed race, and more than 50% had public insurance. Interestingly, there was no difference, and demographics did not predict HBI development. Of the 45 people who met HBI criteria, they were mostly because of persistently elevated liver enzymes. Only 2 had normal liver enzymes, but abnormal liver imaging. Moving to liver imaging, less than 50% had abdominal ultrasound during the study period. Actually, this is not surprising because the guidelines that recommended the screening were issued later. Half of these had elastography, and the findings of liver enzymes are summarized here. Moving to our primary outcome, only 5 out of the 45 people with HBI received the full liver evaluation that was recommended by the guidelines. 21 of our cohort had no additional liver evaluation, so they met HBI criteria, but did not have any further evaluation to see if they have other reasons of liver involvement. This table summarizes the blood tests that were obtained in our cohort during the study period. We can see that celiac disease specifically was higher, almost 50% had celiac screening. I suspect that was in addition to HbA evaluation. These patients had other symptoms, either failure to thrive or abdominal pain or diarrhea that resulted in getting celiac disease. That was higher than the other labs. Quarter of our cohort had at least one of these labs. Regarding our main predictor, chart documentation of HbA, less than half of our cohort had an ICD code or a diagnosis of liver involvement in their chart, but 80% of these had further evaluation, and that's compared to only 15% on those who did not have documentation in their chart. The second predictor was CFTR modulator use. In our cohort, 64% were on CFTR modulators during the study period. Of these, 51% did not receive any further liver evaluation. That's compared to 44% in those who are not on CFTR modulators. This was not statistically significant, though, but this brings up a good discussion point of when do we screen people who are on CFTR modulators for other causes of liver disease? Should we consider this liver enzyme elevation as drug-induced injury, or do we need to actually evaluate further? The guidelines did not mention that, but I would love to hear what do other centers do and when do you evaluate more? This forest plot summarizes the univariate analysis of predictors of receiving further liver evaluation. The y-axis are the predictors, the x-axis is the odds ratio. On the right side, you can see odds ratio with a 95th confidence interval and p-values. We can see that seeing GI outpatient actually increases the odds of receiving further liver evaluation. You can see that HbA documentation is the strongest predictor of receiving further evaluation. So those who have HbA documentation are more likely to receive further evaluation for causes of liver involvement. CFTR modulators does have the trend of having less likelihood of getting further evaluation, but as we can see, that was not statistically significant. So to conclude, we identified gaps in HbA evaluation in our cohort. Liver workup was only done completely in 11% of our population. 46% did not receive any further evaluation. HbA documentation was less than 50% of our cohort, and CFTR modulator use might have affected getting further liver evaluation. Most importantly, those who with HbA documentation and GI care were more likely to receive additional liver workup. Now, what is next? Regarding GI follow-up, during the study period, we actually had one GI provider caring for people with CF in two different sites, East and West Bay, as you can see on the map. But starting 2023, we actually have now two GI providers, one at each clinic site. And our goal is to have an annual follow-up, at least one outpatient GI visit for each person with CF followed in our clinic. We are also conducting an implementation science study to assess the knowledge gaps through surveying the CF clinic team members. We're also assessing barriers and facilitators through doing one-to-one interviews with the CF team to identify what are the areas that we can target. Both the surveys and the interviews will inform our interventions of educating our CF team about the new guidelines and specifically HBI and further evaluation, and also hopefully improving a workflow and possibly using the EMR and using other tools that I just learned about today to hopefully implement the guidelines. With that, I'd like to thank and acknowledge the support of the Cystic Fibrosis Foundation Clinical Fellowship Award, the NIH Training Grant. I'd like to thank my mentors, Dr. Addison Cuneo, Dr. Elizabeth Gibb, and Dr. Emily Perito for their tremendous support. Please visit my poster, 610. And thank you.
I'm so sorry.
Okay, so we'll now open up the questions for the 6 speakers addressing the new liver guidelines. Feel free to come to the microphone, or if you don't feel comfortable, but we already do. So go ahead.
Hi, I'm Mel Collins. I'm a pediatric pulmonologist from Connecticut Children's. My question is specifically for Dr. Assis. So we have really started to appreciate the amount of alcohol experimentation that our teenagers and our college students are doing since the advent of Trikafta, and we've picked up many a fun-filled weekend on just our routine screening labs. So we've tried to take a more active approach in our discussion about use of alcohol. A question that I'm frequently asked, and admittedly all of our patients are underage 21 in the state of Connecticut, so they shouldn't be consuming alcohol. But a question I'm frequently asked is, what is a safe amount of alcohol consumption? I'm actually a non-drinker, so I smile and say none. And then I've started to get asked questions about edibles with the advent in our state of that being legal as well. So I was just wondering from like an adult sort of perspective, what do you recommend about alcohol consumption in this population, or even, I don't know, what your take on edibles is, but it would just be helpful.
Yeah, that's a good question. Thank you. It's a tough one. I think standard hepatology advice would be if you have any chronic liver disease, there probably is no safe amount. That would be standard advice. I think obviously with advanced fibrosis, I think you can be even more dogmatic about that, but you're also talking about a population that's very young and could end up with consequences for a long time. So I think it's reasonable to at least present the argument that if particular any hepatobiliary involvement, there's no safe amount. I think when it comes to edibles, there's really no data on that. I know that we're also feeling a lot of those questions. Again, it's a little difficult. I think certainly for the inhaled stuff, there's a little bit of higher risk of infections. That's an obvious one. But honestly, I think the other aspect to maybe present to a patient is that increases the risk of some inadvertent drug-induced injury, because a lot of these things are obviously unregulated to the point of knowing what chemically is there. So if you see rising liver enzymes or something else, you have to dig further to see if that could be related to an edible. So I would probably discourage it, but I understand. I think just asking and being aware of it can help to put a new clinical event together a little bit.
I'd like to add on to that too with my own question, as far as along the same lines of in adults, we have several of adults in our center that are looking to the use of ketamine therapy for mental health management. And we do struggle a lot with really elevated LFTs, and what, if anything, is there any data out there? Do you have a statement on that?
Not really. What I would say is that if somebody is going to start ketamine, they probably should have, first of all, they should be up to date with standard screening and diagnostics. I think it would be imprudent to not have at least the knowledge of what the liver is doing or not doing. And so while I wouldn't discourage somebody from going onto that therapy, if there was undetected or maybe the EMR hadn't screened for hepatobiliary involvement, you might probably know that up front. If it's there, I would probably feel more comfortable having a GI monitor along. So part of this is not to say it's unavailable, but to not be surprised 3 or 4 months later and not know what the baseline was.
And increased monitoring, it sounds like.
Absolutely, yeah.
With the GI also. Thank you. Mm-hmm. I don't know that this is directed at anyone in particular, but delicate question, are the changes in screening guidelines for liver disease expected to change outcomes if there are no effective treatments when results are abnormal? the first rule of screening being screen only if you can change the outcome.
That's a great question. I also take care of patients with primary sclerosing cholangitis, or PSC, and one of the debates that we have internally and with patients, of course, is when you screen earlier and earlier for that particular condition for which there is no effective therapy. You have a lot of worried patients, understandably, but you also don't have effective medications to prevent progression, those who will. So I think, one downstream consequence I can already envision from this improved screen is you're going to have a lot more patients and families saying, wow, I'm so glad we detect that. What do we do next? And then the question is, well, we will monitor and hope for the best. And so I think we have to be also prepared for those types of conversations. But I would say on the counter to that, as a negative, is that one of the parents of a parent of a patient with CF who was in the writing committee, I think presented another counter argument, which is like, I don't want to know in 5 or 6 years that my child needs a transplant, and we never really knew this all along. So I think there's a balance to that, and having early detection and maybe monitoring for progression is the right subpopulation to identify. And I can only hope that with better research and better treatment tools in the future, we'll know who to offer them to.
Yeah, I agree completely. And that's what our struggle is the what to do next. But it's all about optimizing the things you can optimize, right? So if we know that there's high risk of nutritional complications with liver disease, or we're concerned, that the patient's not on a good trajectory with their nutrition, maybe we can optimize that. Or with rising rates of pediatric obesity, like I alluded to, maybe we can mitigate that if at all possible in terms of adding MASH or MASLD to your patient's list of hepatobiliary disease. So we all hope for a day where we have a good treatment option, but I think for right now it's preparedness, and I think sometimes that might be shared decision making to the point of, I think, the CRMS guidelines of chatting with your patient. If these are new guidelines, the purpose is to have more information to mitigate complications, but really explaining that there isn't necessarily a treatment coming down the pipeline. So kind of how does your patient feel about that, and what do they want to know about that, and sharing the knowledge that we have.
I'll add one last thing in terms of what we were seeing for screening for alternative diagnoses to CF-related liver disease alone. This is something that is not being frequently done, at least for the folks that we had presented, of which some of those things do have effective treatments. While I agree that primarily CF-related liver disease by itself does not currently, we don't know how many we're going to pick up who have primary liver disease of some other type, which may ultimately be able to be treated and remediated.
We can take the microphone. Yep, go ahead, Erin.
Hey, no, I just absolutely wanted to throw in a plug for CF dietitians, and I 100% agree with you that there may not be a specific therapy, but I think nutrition is a huge preventative thing, and you do, as many of us have been through PEP, as you know, you have to, and you're going to get people who will tell you, not interested, don't care, not interested, doesn't matter about my liver, but yeah, I think as long as they have that, we're screening people, we're identifying these people that weren't being identified before, we're asking them if they're interested in further nutrition education on ways to keep their liver healthy through nutrition. I think this is going to be a huge new push.
Thank you.
I have a question that's directed specifically to Dr. Lazar. Are you performing annual POC-TE in your clinic, even for those patients without CFLD? I thought this was only needed in those who identified liver disease, and would like more clarification on what information is provided by each test, elastography versus ultrasound, and timing for when each is performed.
Yeah, so our clinic, before the new guidelines came out, we got kind of aggressive with point of care transient elastography, or FibroScan, for those of you familiar with the brand name. And so we did start doing it on everyone at least once a year as part of our kind of internal liver screening. It's not necessarily part of the liver guidelines that were released to do that every single year, but that is something that we're kind of starting to review the data to try and figure out if is it something we really should continue doing, or can we back off a little bit in terms of knowing there's already a lot of things that our patients do in clinic. But the nice part of it is they're there and we're doing it in clinic. It's not an extra trip. As far as kind of ultrasound goes, our practice, so guidelines say starting at age 3, get an ultrasound to look at the anatomy of liver and spleen, and do that every 2 years. Says kind of through childhood, and it's unclear if that really means all the way until you transition them or if we should stop it at a certain point in time. We are just starting to really do that. We have not been getting annual or every other year or even every 3-year ultrasounds. We've been functioning much more as kind of reactive ultrasounds, getting them when there are abnormalities. But what we are doing is we are getting elastography with all of those baseline ultrasounds and following the elastography. So that would be shear wave and radiology. In order to provide a baseline for our patients. So for those of you who have been following this for a long time, there actually are there's not really pediatric standards for elastography. And so what every single one of our radiology colleagues puts in their report is, this is on the upper limit of normals, or this is within the established range for adult patients and can function as a baseline for this patient going forward. So that's how we're treating it, is this is what our patient is now, and we're going to follow it forward and use them somewhat as their own baseline, knowing, of course, there are some established abnormalities. So I hope that clarifies. I don't think you have to do a transient elastography on all of your patients annually. That is something we have been doing, but I don't know if we're going to keep doing it every single year, because that is a lot, but kind of trying to figure out what our algorithm is going to be moving forward.
Go ahead.
My question is regarding medications. So obviously one of the things that's great about coming to the meeting is getting clinical expertise that might be outside the guidelines. At our center, we have found benefit with ursodiol and with the pressure to maintain our patients on ETI from the patients, right? They feel much better very quickly. So by the time you get that first LFT that's really going to prompt you to stop, they already feel amazing and they don't want to go back. So I was just wondering what your practice is regarding ursodiol. And then in my short course, I heard someone mention something called oxbile that I've never heard of before, but anecdotally was very helpful to them. So I was just wondering from our GI experts, your thoughts on these medications.
You want me to go first, or you go first? Okay. Yes, ursodiol, we've slowly been peeling it back. We didn't have a lot of patients that were on it, but we were and still are using it selectively. So I mentioned in the presentation, so maybe a patient with comorbid disease like biliary atresia, but there are still instances where if we have a patient who's on a medication that is known to cause liver enzyme elevation that requires monitoring, so fluconazole is sometimes an example of that your patient might be on. And especially in an effort to maintain them on that therapy, we'll start ursodiol, use it for the duration of therapy, and then peel them off of it. As far as modulators go, we haven't routinely been starting ursodiol in the case of modulators. What we've been doing more commonly with modulators is doing a modified dosing regimen for patients who already have elevated liver enzymes, and then checking labs. So maybe doing 1 dose a day, Monday, Wednesday, Friday, and then getting labs in a week, seeing if we've had any change in our enzymes, and then trying to check again in 2 weeks, check again in a month, and then try to push the dosing up if things are staying stable to full dosing if possible, and if not, have them on some sort of modified dosing long term. We haven't been using ursodiol in order to help us push forward necessarily. We've been focused more on the modified dosing regimens.
Just really likes ursodiol, so it has been helpful to maintain our patients on full dose because we don't have pharmacokinetics for ETI available to know if the patient, when you modify, is actually getting the therapeutic dose.
Yeah, I think it's a lot of it's style. So that's kind of in our practice. I'd love to hear what Dr. Assis thinks
Yeah, no, that's a great question. I mean, with regard to ursodiol, I give a lot of it for patients with PBC and PSC as well. So it's we get kind of facile with it. I think if there's any degree of cholestasis ongoing, I would be a little hesitant to stop it. There's a nice article in PSC patients in which when you stop that, you get a rebound cholestasis, which can lead to symptoms and increased liver enzymes and even jaundice. So presumably if somebody has been on it as a preventative measure and they have no abnormalities of the liver, I would be more comfortable stopping it, number one. Number two, I think we have had some anecdotal cases in which URSO made the enzymes improve enough that the pulmonary team was comfortable continuing with ETI, so we're not above trying to have a workaround, so to speak, in addition to modifying the dose. I would just say that probably when that happens, we have to be probably vigilant with FibroScans, because there could theoretically be an increase in fibrosis that you could miss despite having the enzymes look normal. So you probably have to have an additional level of safety and reassurance beyond that. And then furthermore, of course, the majority of the enzyme elevations, depending on the case, can be more hepatocellular, so it may not exactly impact that, but we've tried that in some cases with some good success. But we're not starting it anew in anyone outside of that circumstance these days.
And then you asked about Oxbile. I'm actually not super familiar with that, so I'm going to go look into it. Yeah.
I found it on Amazon.
Yeah.
But then, I'm always uncomfortable with Amazon's links and to be.
Yeah, there are a lot of natural products that have some bile acids, which actually some of our patients who've kind of self-treated for cholestatic liver disease with some of those components have actually done remarkably okay, but it's a watered down or a partial version of UDCA. So if you were going to treat, I would treat with UDCA. There's no added benefit. It's just that there's some bile acids in that component as well.
Okay, we are out of time. We thank all of our speakers for being here today and for being available for questions. Thank you very much. You each did an amazing job. Thank you to the audience.